Well, good afternoon, everybody. Nice to have people in the room and some guests in the room, and also plenty of people joining us online this afternoon for our presentation about our work with World Child Cancer in Malawi. Many of you know that today is Giving Tuesday, and in this presentation, we like to think that we're giving everybody that comes along to this presentation a gift. An opportunity to see the impact that you're making as a result of the support that you bring to international health partners. And our gift to you today is inspiration and a sense of the way that we work and the impact that you can make to enable access to medicines for people across the world. We're delighted to be able to welcome you, and we hope that as you hear more about our work, you'll understand about the importance of partnerships with great organisations like World Child Cancer. And we hope you'll understand why we do what we do, getting the right medicines to the right people at the right time. So I'm very happy to welcome you all. I'm delighted to hand over to Hannah and Johnny, who are going to be taking us through this presentation this afternoon. Thank you.
Thanks, Adele. So yeah, welcome everybody. We're delighted to finally be here to share this presentation with you. So as Adele said, my name's Hannah and this is Johnny, and we're part of the programs team here at IHP. And one of our roles is to manage the relationships with our network of partners, and that includes World Child Cancer. So we're delighted to welcome Ghazala with us today, who's here with us in person. And so let's take it away. Just a few housekeeping things just before we start. If you could, I know I asked some of you, or all of you, if possible, to bring your phones. Don't worry if you didn't, but if you could put them on silent, that would be fantastic. And also, we're going to be covering some quite sensitive content today in terms of talking about some stories around childhood cancer. We've all been affected by cancer in different ways, and that's going to impact us differently. So please do feel free to leave the room if you're here in the room, or online if you need to take a break. That's totally fine. Please just do that at any time. Cool. So let's take it away.
Great. So hi, I'm Johnny, and I work closely with Hannah in the programs team at IHP. So to start off with, let me tell you some background information on Malawi. So Malawi is a Southeast African country bordered by Zambia, Tanzania, and Mozambique. And you can see we've got a map on the screen there. It has a population of 20.4 million, and it's one of the most densely populated countries in South Africa. However, 82% of the population lives rurally. A huge 51.5% of the population are living below the poverty line. Economically, Malawi is one of the world's least wealthy countries by any metric, with the International Monetary Fund estimating it's 183rd in GDP per capita. Malawi's Human Development Index is 169th in the world, and 80% of the population is employed in the agriculture sector, with the primary export being tobacco. Malawi's economy is quite vulnerable to external shocks and climate attacks. Extreme weather events such as Cyclone Freddy have been devastating. High inflation, with figures such as 28.4% in July 2023, and a severe shortage of foreign currency are part of a very difficult economic situation. Malawi also has some systemic health issues. The life expectancy at birth in 2021 was 63 years, and there's only 0.1 physicians per 1,000 population in the country. And when you compare that to 3 per 1,000 in the UK, it seems very small. The under 5 mortality rate is 41.9 per 1,000, which is 10 times higher than the UK's 4.2 per 1,000. Some of Malawi's primary health issues include HIV/AIDS, respiratory infections, malaria, diarrheal diseases, and perinatal conditions. The non-communicable disease burden has been on the rise as well, and it now accounts for 40% of the mortality in Malawi, along with injury. So the health system in Malawi is split between the public sector and the private sector, and the public sector healthcare, which is coordinated by the Ministry of Health, is provided free of charge, and it has primary, secondary, and tertiary tiers, of which the hospital, Queen Elizabeth Central Hospital in Blantyre, is a tertiary tier hospital. Unfortunately, 70% of the services offered at the tertiary tier are for conditions that should be treated at a district hospital or a local health centre.
So as we said, this programme of ours focuses on childhood cancer. So we just wanted to give some kind of definitions of some of the cancers that Johnny and I saw when we were in Malawi with World Child Cancer. And because some of these look very complicated, so we were like, let's give some definitions. So just to remind everybody what cancer is, that's a condition where cells in a specific part of the body grow and reproduce uncontrollably. So the cancerous cells can invade and destroy surrounding healthy tissue, including organs. And cancer can sometimes begin in one part of the body and spread to other areas. And that process is known as metastasis. So here on the left, we have a cancer type called Wilms tumor, which is a type of cancer of the kidney, and it most commonly affects children. We also have Burkitt lymphoma, which is a type of non-Hodgkin lymphoma, which is a cancer of the lymphatic system. So it develops when the body makes abnormal B lymphocytes, so they're part of the immune system. And lymphocytes are a type of white blood cell that normally help to fight infections. So when you have a lymphoma, the abnormal lymphocytes build up in the lymph nodes and other organs. And so Burkitt lymphoma grows really quickly, and you need to treat it really soon. As soon as you've been diagnosed, you need to be treated straight away because of that replication. Next up, we have a retinoblastoma. I think you can probably all figure out what that is, but it's basically a rare type of eye cancer that affects young children, and it affects the retina, which is part of the back of the eye. Next up, we have acute lymphoblastic leukemia, which is a rare type of cancer that affects the blood and the bone marrow. We have germ cell tumour, which is a tumour that develops in germ cells, and these are cells in the body that develop into either sperm or eggs. Tumours of this type are most often develop in the ovary or the testicle, in either male or female, and because that's where the most germ cells are. So last up, we have rhabdomyosarcoma, which is a type of soft tissue tumour. And these tumours develop either in the muscle or the fibrous tissue and grow in any part of the body. Most children with this are younger than 10 years old, though, and apparently it's more common in boys than girls.
So we'll now share a bit of background information on the topic of child cancer in Malawi. So going clockwise from the top right, the first thing to mention is that access to oncology medicines is a major issue for children with cancer in Malawi. Services are hampered by a poor availability of chemotherapy drugs and supportive care medicines, including those for palliative therapy. According to World Child Cancer, the government only supports 10% of the cost towards required medicines. Therefore, around 90% of the drugs required must be provided by donors.
And next on the list, we have limited diagnostic capacity. So most cancers diagnosed and treated in Malawi are easily treated solid tumours, such as Burkitt lymphoma, which we just learned about. This is unfortunately due to a lower diagnostic capacity compared to other comparable countries, where things like leukemia, brain and central nervous system cancers are most common. So again, according to World Child Cancer, when we were there, 1,200 children are expected to develop cancer per year in Malawi, whereas only approximately 500 of those patients are actually diagnosed, and even fewer actually receive treatment.
Then, according to largely incomplete cancer registries, the incidence of cancer in children between the ages of 0 and 14 years in Malawi was about 308 per million between 2003 and 2010. So by 2050, almost 50% of the cancer burden in children younger than 15 years will be in the continent of Africa.
Another issue that we heard quite a bit about was late presentation and with advanced disease. That was something that came up, and you'll hear a bit about that in some of the case studies we'll share. So children with cancer in Malawi often present late with advanced disease. And according to the Journal of Clinical Oncology's journal, Global Oncology Journal, it is estimated that between 50 and 80% of patients with pediatric cancer in sub-Saharan Africa present at a really advanced stage. So delays can occur at any time during the care-seeking process, from symptom onset to treatment initiation. Clinicians in country told us that they get a high proportion of late presentation, which requires heavy treatment regimens for affected children, and also increases the mortality rate of children with cancer in Malawi.
Next, we have the low socioeconomic status of many families in Malawi, which leads to increased chances of missing treatment. And then that increases the chance of having a relapse in your cancer. Treatment abandonment is also an issue, which can result from many different sources. Families may also misunderstand the recovery stage of their child. Often, the cost of treatment or transport can cause continuation of treatment to be quite expensive. In addition to that, guardians may have other family members at home who they can't support while caring for their sick child at hospital for long periods of time. Families may also, oh, I already talked that.
Yeah, so next up is a lack of education when it comes to cancer in Malawi. So that has a great impact on the outcomes for children with cancer there. Parents with little education or awareness about cancer might not recognise the symptoms in their child, and clinicians without access to cancer diagnostic capability may not be able to detect cancer in its early stages. So referral delay, the time from the first presentation at a health facility to all the way up to an oncologist evaluation is a key component of the total delay that's not really been evaluated in sub-Saharan Africa, but we know contributes to it. So one of the other barriers to child cancer care is the lack of paediatric oncology training and specialists. So Richard, who's the program coordinator with World Child Cancer in Malawi, explained to us that delays start in communities and then at the primary healthcare level. So that's the local clinics. By the time patients come to the tertiary level for cancer treatment, it can be too late.
Next, we have the cancer and infectious diseases point. So studies have actually suggested that childhood cancer in Malawi is affected by infectious diseases. The Epstein-Barr virus, which exists all over the world and normally causes mononucleosis, but only in a few percentage of people, is also implicated in Hodgkin lymphoma and Burkitt lymphoma, which are two childhood cancers. Plasmodium falciparum is a malaria-causing microorganism that's endemic to Malawi and other nearby countries. It has also been shown to increase the risk of developing Burkitt lymphoma. It does this by acting as a cofactor in the cancer's development stage alongside the Epstein-Barr virus. So that might increase the prevalence of childhood cancer in Malawi.
The next up is the low level of monitoring and research. So Malawi does not have a great amount of cancer research and monitoring in countries such as that incomplete cancer register that we heard earlier. So that reduces the confidence of monitoring efforts and stems partly from a lack of funding and infrastructure compared to wealthier countries. There's also no specific cancer strategy in Malawi, according to what we heard when we were there.
Cultural beliefs might also affect child cancer care in Malawi. Local beliefs and myths about cancer treatment may lead them to avoid modern medicine and use remedies from traditional medicine practices. And this can exacerbate the problem of late presentation.
World Child Cancer works primarily out of Queen Elizabeth Central Hospital in Blantyre, which we'll hear more about shortly. And they coordinate closely with another organisation called Global Hope, who operate out of the capital city and the Lilongwe. Together, these organisations operate the majority of the child cancer care in Malawi. So these are primary treatment centres for child cancer are based out of Kamuzu Central Hospital in Lilongwe and the Queen Elizabeth Central Hospital in Blantyre. Both of these, as Johnny mentioned before, are tertiary level facilities, and we visited both of them during our time in Malawi.
And then finally, cancer and its treatment can increase the risk of malnutrition, which is already unfortunately common in children in Malawi. So according to UNICEF, as of May 2023, at least 573,000 children under 5 are at risk of suffering from malnutrition in Malawi.
So we're delighted to then tell you a little bit about World Child Cancer, who's our program partner operating out of Malawi. So this is Richard. He's the program coordinator there and worked so hard during the time that we were there to help us get all the content for you to hear today. So World Child Cancer is a leading international children's charity dedicated to addressing the global inequity in childhood cancer treatment and care. Their mission is to improve diagnosis, treatment and support for children with cancer and their families in low to middle income countries around the world. They were founded in 2007 and now support 13 programs across Africa, Asia and Central America. Their model is to partner with hospitals in each of the countries that it supports. So in Malawi specifically, Malawi was actually the first program that World Child Cancer implemented, and that started off in 2009. They partner with the Paediatric Oncology Unit at Queen Elizabeth Central Hospital in Blantyre, which you might hear referred to as QECH in some of the case studies. That's this hospital. And this is led up by Dr. George Chakaluka, who we'll hear more from later. Richard is the programme coordinator, as I mentioned. He supports the programme planning, implementation, M&E and grants management, and also carries out community engagement and training initiatives. So some of the pillars of work that World Child Cancer have were really impactful, and Johnny and I were really mulling on these as during our time there. And we can see lots of ways that World Child Cancer are impacting these pillars. You'll hear some of this in some of the stories later. The first is that no child should suffer. So World Child Cancer seeks to improve the quality of cancer care by capacity building, training and providing equipment, and also with the provision of medicines through the IHP partnership. The next pillar is no one left undiagnosed. So World Child Cancer provide training to healthcare workers at the secondary healthcare level. And we heard during our visit, they're starting to implement that at the primary level as well. So they're trying to get down to the root of that to try and raise awareness as soon as possible to prevent that late stage presentation. So since 2021, they've trained 517 healthcare workers with more training sessions planned. And they contribute to facility research, increasing diagnostic capacity, increasing community awareness of childhood cancer as well. The third is to help families. And this is something that you'll hear in the stories, how it impacts the wider family, not just the child affected. So World Child Cancer provides psychosocial support to children and their families through the provision of a play therapist and also access to a psychotherapist as well. They support with hospital transfers, so the cost for patients to get to the hospital as much as they can. They try and offer that service. They provide welcome packs to families that includes maize flour, toothpaste, and soap, and that's been really, we could really see the impact of that while we were there, because families have to stay there for long periods of time. And they also support the hospital school, so the hospital has a school with necessary equipment to kind of support the patients who can still try and access education while they're being treated. The final pillar is that the world must know, and they are trying to diversify policy and public opinion to do more on childhood cancer in low to middle income countries. And we heard from Richard that World Child Cancer wants to move towards a 60% survival rate of cancer in children in Malawi.
Well, so let me take you through a bit of the history of our partnership. You can see on the screen some lovely puppets that World Child Cancer uses as part of their care for their patients. So IHP have been working with World Child Cancer for a few years now. Our relationship formally began in 2020, but we launched our first shipment to Malawi in their partners' facilities in 2021. The shipments we've sent together have included all the products on this slide. You can see a list on the slide on the left there, which includes chemotherapy drugs such as carboplatin and cisplatin, as well as ancillary cancer care medicines such as ondansetron and prednisolone. In total, we've calculated that over 14,000 courses of treatment have been sent, with a total value of around £3.2 million. Using a conversion of about 8 vials to one person, a conservative estimate would approximate that over 1,700 patients have been treated by these shipments. We're also shipping another high-value shipment of cancer medicine this week to Malawi with World Child Cancer, and that should contain another 29,000 courses of treatment and a value of about £74,000.
I think we heard this morning that was on its way, didn't we? Which is great news. So, yeah. Awesome. And so we just wanted to share a little bit about our visit, what we were there to do, why we were there, what we were trying to get out of it. So we wanted to better understand the priorities, needs and context of World Child Cancer's programme in Malawi. We wanted to visit the health facilities and see how the medicines are being managed and used. As part of this, Johnny completed a good distribution practice audit of the facility where they store the medicines that we donate and check that they're being handled correctly. We wanted to interview patients, their families, healthcare professionals working on the ward, and World Child Cancer staff as well, to illustrate the medical needs and the impact of our partnership together. We wanted to document the specific need for oncology medicines and scope how we can further as an organisation support the diversification of the types of products and instill a more sustainable supply of those products to the programme. So we wanted to document the donations that have been used so far, and also look at ways that we can strengthen the partnership with World Child Cancer further, whether that was to provide other technical support around impact story collection and images, whether that was projection of product needs for the following year, importation, distribution, and also just to look at other ways that we can collaborate and grow that partnership further.
Cool. So, as we've mentioned previously, the primary site we visited during the trip was the base of World Child Cancer's operations in Malawi, and that's Queen Elizabeth Central Hospital in Blantyre, Malawi, or QECH, as it's been referred to a couple of times. So this is the main tertiary care centre for children with cancer in the southern region of Malawi, and it provides them with diagnosis and treatment. As the main tertiary healthcare facility, all the district hospitals in the southern region refer cases to QECH. They also receive patients from as far away as the northern region of Malawi and even Mozambique. So there are 34 beds on the paediatric oncology ward, and most of the time the ward is completely full, although through the work of World Child Cancer, the ward has been expanded already from its original size. They run daily clinics, on average seeing about 10 patients per day at the clinic, and given how full they get, there is a need to increase the capacity even further. World Child Cancer's work on addressing diagnosis challenges is causing QECH to see an increase of patients coming through, so those needs seem to be catered for. So the hospital diagnoses about 30% of the 1,200 expected cases in Malawi per year, and as we mentioned previously, that mainly composed of Burkitt lymphoma and other easily treatable solid tumours. The centre provides healthcare free of charge, but the government funding it receives, and this is across the whole hospital, is insufficient to its needs. Many costs end up falling on families to fund themselves. Unfortunately, that can create real barriers in treatment and sometimes forcing families to abandon treatment. The work of World Child Cancer really helps to overcome these difficult barriers by supporting them with some of the costs around the long duration of hospital treatment for children with cancer in Malawi. So we'll now move on to doing a few case studies. So I believe, Lily, you have the first case study. So let me just hand over my microphone to you. So don't hold it too close to your face. That sounds great.
Okay. My name is George Chagaluka, and I'm the head of paediatrics and child health at the Queen Elizabeth Central Hospital. In addition, I am also head of paediatric oncology. My goal is to make sure the department has the resources to run optimally, but also to make sure the patients that come to the department can get the care they deserve. My role is very important in Malawi because, like most low-income countries, Malawi has a high burden of childhood cancer, but it has very few specialists to look after children with cancer. I am one of the few specialists that are represented in Malawi. I therefore have to make sure that the patients get the best out of me. One of the major challenges is late presentation. When I say this, I mean patients that come to us with advanced disease and need a high intensity protocol to get cured. In addition, there is a shortage of medicine in the hospital that patients need. The geographic challenges are many. Blantyre, as a treatment centre, is located at the southern tip of Malawi. Most patients come as far as the northern region to access care here, which is about 800 kilometres away. In addition, a large portion of patients come from Mozambique and rural parts of Malawi. The health context in Malawi is affected by numerous exacerbating factors that make it more challenging. One of the major contributions is malnutrition, and another of the biggest factors is a lack of awareness about the disease. A child may have leukemia, but the family is affected by myths and beliefs about the disease, which causes delay in presentation to health centres. The majority of Malawians are malnourished, and cancer worsens the burden of malnutrition. Every month, we treat about 20 to 30 patients. Over the course of a year, we have 250 new patients at the QECH. A lack of access to medicine results in a declining survival rate for childhood cancer. Furthermore, relapses would be common, and these are difficult to treat. Relapses in an environment where medicines are scarce complicates the issues. We need a steady supply of this medicine to improve survival of childhood cancer in low resource settings. As a doctor, when we don't have access to the medicines we need, it is a sad moment when there is a child in front of you looking for a cure and there is no cure. It is not only sad for me as a person, but also frustrating as a doctor, and also frustrating to young doctors who have just graduated, and this contributes to a brain drain in the future. IHP has been very helpful to us. Over the time of our partnership, we have had a good number of medicines coming to us. We are very grateful to IHP and for all the donors that have contributed to IHP over time. To supporters of IHP, first of all, I'd like to say thank you. There is a saying, "Blessed is the hand that giveth." Please continue giving.
Great, thank you so much. So you saw a few themes in that story that we were mentioning, maybe some of the challenges with childhood cancer in Malawi. So some of those themes were there's few paediatric oncology specialists, there's issues with late presentation and advanced disease, access to medicines can be a barrier, geographical challenges for patients who live far away from the tertiary facility, malnutrition and the contribution of that to the burden, and also some of those cultural beliefs as well.
Great. Hannah, do you mind giving your microphone to George, who I think has the second story?
Okay.
My name is Chifundo, and I am from Chileka, which is about an hour away from Blantyre. I have sold tomatoes for about 10 years now, and my husband is a builder. We have 9 children at home who range from 23 to 3 years old. I noticed a mass appeared on the left side of my 6-year-old son, Emmanuel's stomach, so we went to the health center in Chileka, who then referred us to the Queen Elizabeth Central Hospital on the same day. We knew that it was serious as we were referred to the special care ward, not the pediatric oncology ward initially. It took some time to determine that Emmanuel had cancer, which was a frustrating process. When we were sent to the pediatric oncology ward, I spoke with Dr. George. We had to stay here for a month for Emmanuel's initial treatment and then have been coming in for chemotherapy once a week for a few months now. We struggle to get by and even buy food in normal times, and so we won't be able to buy the medicines as they are very expensive. Originally, I was dependent on selling tomatoes, but I can't sell them at the market anymore because we are at the hospital, so my business has come to a complete stop, which has been difficult. Thankfully, there is no cost to me. Everything is supported by World Child Cancer, and we have never paid a penny, even for our transport. The treatment we get here is really good, especially the medicine. We have been supported well and have seen an improvement in my son's health. Our lives have changed tremendously, but the free medicine has helped to save my child. We are very hopeful for a bright future for Emmanuel, a cure and freedom to return back to our normal lives.
Thank you very much, George. So that story speaks to some of the difficulties that many families affected by childhood cancer can experience. Emmanuel's cancer affected his family's ability to work and support themselves, since Chifundo could no longer attend to her usual livelihood. Thankfully, Emmanuel's treatment is free at Queen Elizabeth, and World Child Cancer was able to support the family as they go through this period. Okay, so the next, I think, Tina, do you have this one? I'm going to hand over my mic to you, Tina, because it helps with the script.
My name is Asal. My baby's name is Lindani, and my daughter's name is Mimi. We live in Bangula, which is about 2 hours from Blantyre. Mimi is 11 years old, and her favourite subject at school is maths. She has a big imagination and loves to play families with her friends. Mimi started to develop a swelling around her eye, so I took her to the local health centre, who then referred us to the district hospital. Once there, they referred us here to QECH. The cost for travel to get here was a challenge, so I had to do some farming to pay for the transport. Once here, they ran some tests and we found out she has retinoblastoma, which is a cancer of the eye. Mimi received initial treatment and was discharged. Sadly, her cancer has relapsed, so we've had to come back and start treatment again. I have noticed an improvement in her condition. We've been here for 4 months this time, but I have 2 other daughters at home. One is 8 and the other is 4 years old. I managed to go home for a week to see my other children, but that has been the only time I've returned. We're not sure when Mimi will be discharged and when we can go home. When she's older, I want Mimi to be a teacher, as that is what she tells me she wants to do. Thankfully, we have received all the medicines Mimi needed for treatment free of charge. We have received really good care here. Matron Anisia says, Mimi was originally diagnosed with retinoblastoma, but has sadly relapsed and has been subsequently diagnosed with Burkitt's lymphoma. She is on oncology drugs, including cytarabine and doxorubicin. She's also receiving omeprazole and ondansetron to help manage sickness, which is a side effect of chemotherapy. She still has a low white blood count and has been on treatment for quite some time. So far, she isn't responding well to treatment, so her prognosis is uncertain.
Thanks for reading that one. So you probably heard from that story that travel implications was a barrier for this family, and that has resulted in the mother not being able to return home that month in such a long period of time and having to leave her other children at home and not being able to see them. So you can see how this impacts wider families of children who are affected. You'll also see that there's unfortunately been a relapse in this case, and sometimes that can happen, as we said, for lots and lots of different reasons, and this has then subsequently resulted in a secondary cancer diagnosis.
So I think, Heather, do you have Esther's story?
Yeah. Esther came with her 7-year-old son Peter to the hospital seeking treatment for his eye after he came out from school one day and said his eye was painful. She noticed that his eye was red in colour, and so they initially sought treatment at their local health centre. Esther said, "The doctor gave Peter eye drops for an eye infection and sent us back home, but these didn't work. I went back twice more, and the doctor saw that the eye was swollen and was starting to come out. I then took him to the district hospital instead. They carried out some tests and gave Peter more eye drops, but still thought it could be an eye infection. After 3 weeks, there was no change, and so the health clinic referred Peter to the Queen Elizabeth Central Hospital." Esther explains, "We left at 5 a.m. and arrived at 11 a.m, so it took 6 hours to get to the hospital. We took public transport on minibuses from the village and then had to either take a motorbike or walk, but taking the motorbike is expensive. I came here and was first sent to the eye clinic, and Peter received treatment there for 2 weeks before being referred to the paediatric oncology ward. When I visited the ward, I met with Dr. George, and they did some tests and scans and diagnosed my son with rhabdomyosarcoma, a type of eye cancer. This was heavy news, and it was traumatizing. I had not heard much about cancer before, only pieces of information. However, it was a relief to finally have a diagnosis. I had previously thought it might have been witchcraft, but it was good to know that the eye disease had a source. Thanks to the support from the hospital, I have been able to pull through and have seen the improvement in Peter's eye, which is a relief. Peter has now been here for a few months and receives treatment every 3 weeks.
I'm thankful to be receiving medical care for free, otherwise it would have been too expensive. The rest of the family are back at home and living together. Usually everyone lives separately, but recently they've been supporting one another and have shared out responsibilities. In the future, I hope I can return home with Peter in good health. This would make my joy complete. I'm excited to be returning home soon, as it has been a long time at the hospital, and I'm ready to return to normal life, to work, to church, and to my family.
Great, thank you, Heather. So Peter's story touches on two of the common issues faced by families affected by childhood cancer in Malawi. Unfortunately, initial misdiagnosis of Peter's condition as an eye infection caused a delay in his starting eventual treatment. In the same way, local beliefs sometimes have a part to play in delayed start to treatment. Peter now has been able to access treatment for his cancer thanks to the ward at Queen Elizabeth, and his family has hope for their future together.
It's time for a break, a little quiz. So for those in the room, if you've got your phones with you, you can use the QR code there. If that doesn't work, head to menti.com and use the code on the screen. For those remotely, you can do the same, and hopefully we can see if we've got a winner as well. So I'll just give you a few seconds to do that, and then I'll hop on over to the quiz. Right, let me move over. It's all right, you can still get the code if I just hop on in. Did Google just come up?
Oh boy.
Okay, so, oh, you're already in, you sneaky lot. Right, okay then. So question 1, which country does not border Malawi? This is a real test of who's been listening, to be fair. All right then, so have you all nearly, gosh, there's quite a lot of you, isn't there? Right, I'm going to go on and answer now. So 3, 2, 1. Get your answers in. You are correct that Zimbabwe does not border Malawi, but the other 3 countries do. Well done. Sorry, guys, for who didn't get that right, but at least you'll remember it now. So next question. Hang on. Let me just figure this out. Okay, next question is, what is Malawi's primary export? Maize flour, tea, tobacco, sugar, or gold? All right, in 3, 2, 1. I'm impressed. It's tobacco. That is correct. Next question. What is the percentage of oncology medicines provided by donors to the hospital in Malawi? You can't confer, that's cheating. Yeah, I don't know how we did that last time. All right, so in 3, get your answers in. 2, 1. You are correct, 90%. I'm so pleased that you're all awake and listening. All right, I think this is the last question. So how many children get diagnosed in Malawi per year? So how many children get diagnosed in Malawi per year?
Diagnosed with cancer.
Yes, sorry, that was not specific, but you know, you get the gist. Oh, got some.
Let's see who's listening closely.
All right, quick, get your votes in. In 3, 2, 1. Oh, it was 500. Oh, it's a trick question. So basically, there's predicted to be 1,200 children who develop a childhood cancer, but only 500 of them are diagnosed per year.
Okay.
Yeah, well done, guys. That was more or less very good.
We got a majority of good answers from that question.
All right, so shall we move on to another story? Who's got Ida?
Matt. Ida.
My name is Ida and I am a child livelihood specialist. I provide play therapy and a safe space for children who are admitted onto this ward while they are undergoing treatment and various procedures. The best thing about my job is that I make the children happy. Children can often be anxious or sad when receiving treatment or procedures. However, the sessions I provide to the children are full of fun and joyous activities, so they help to make them feel happy. When a child dies, that is extremely traumatic for the parents and the other children in their family, and on the ward as well. In my role, I am able to provide a platform for the children to open up with the things that are inside their heart. Through that, we can talk and find a solution, and I am able to comfort them. This is the same with parents and guardians. I am able to connect with them, and they are able to share to give as much support as possible to parents and to guardians, to give them a more stable mind as they care for their children.
Brilliant. Thanks, Matt. I'm just going to hand your microphone back to Hannah now. There you are. Thanks. So as you've heard, Ida is one of the integral staff members of World Child Cancer in Malawi. Her role as the child life specialist is so important alongside the donations of cancer medication. By ensuring that the children and families are supported as best as possible, affected families are empowered to continue their care. Her work goes a long way to reducing the chance that parents will end treatment and return home with their child, and helps families stay hopeful and happy while undergoing treatment.
It was amazing to see, wasn't it, the amount of like enrichment activities that Ida put on while we were there, and the things that children, you know, they can just play and just be a child while they're there, which was just so lovely to see. And they had lots of activities that they were doing at different times. She put films on. They even had some like bikes that I absolutely had to go on, not gonna lie, whizzing around the ward. But yeah, it was wonderful to see that, and just to make it a little bit more fun.
So I think next we have Katrina. Okay, let me hand you my microphone. So just two places.
Tara said, "My name is Tara and I'm 15 years old, and this is my mother, Madalitzo. My favourite subject at school is maths, and my favourite colour is peach, like my t-shirt. I like playing ball games at home. I have 3 brothers and 3 sisters, and I'm the second youngest of them all. We live here in Blantyre." Madalitzo explains that 4 months ago, Tara started experiencing malarial symptoms such as fatigue and fever. She then developed a mass in her abdomen. We first went to the health centre, who then referred us to the Queen Elizabeth Central Hospital. Tara was admitted to the special care unit for 2 weeks, and from there was referred to the gynecology unit due to the mass in her abdomen. They did some tests, including a biopsy, and determined that the mass was in her uterus. It was cancer. She had to undergo surgery to remove the left ovary, as this had become damaged by the cancer. After surgery, she was sent home and was given an appointment to start chemotherapy. Matron Anitia explains that Tara has been diagnosed with germ cell tumour. She requires 8 cycles of chemotherapy and is currently on her 2nd cycle of treatment. So far, she is responding well. Madalitzo describes that when she came for treatment, which started a month ago, she was admitted onto the cancer ward. We are back for the next treatment cycle, which started yesterday. I'm so thankful that the medicines are for free, as I had fears about this when we came. I thought we would have to pay. We have also received other things for free, such as food. The money we have saved here is helping the family at home. I'm a farmer and I depend on my work. Since Tara has been sick, I've been unable to work, and I'm a single parent. It is my responsibility to make money and provide for my family, but I cannot do that while Tara is unwell. We are struggling financially. I think Tara looks better now. A few months ago, she was vomiting, her abdomen was swollen, and she couldn't go to the toilet. As soon as she received treatment, these symptoms improved. The medication is doing a good job of shrinking the cancer in her uterus. The cancer itself was less concerning for me, as she received treatment quite quickly. My concern is whether she will be able to have children in later in life. This is still unknown. If she is not responsive to the treatment, then they may have to do a full hysterectomy. Tara tells us, when I grow up, I want to be a nurse, as I have such good care here. I have a favourite nurse, but I can't remember his name.
Yeah, she was really trying hard to remember his name, but I think I recognise who it was. So yeah, you see a few challenges in this story that the family faced, which one was that the mother, Majalitso, was unable to work during Tara's treatment, and that caused some implications for the wider family, financially particularly. You also heard that there is some risk to lifelong potential impact for Tara, including the risk of infertility as well.
Okay, so Linda and Innocent. I think Hazel, you have this.
My name is Linda and I'm from a village near Mulanje, which is about 3 hours from Queen Elizabeth Central Hospital. I'm a farmer and have 5 children, 2 girls and 3 boys, and 5 grandchildren. Innocent is my grandson. We are here because Innocent is suffering from cancer. Before he was diagnosed, Innocent loved playing with his friends and had just started kindergarten. One day he started to complain of a stomachache and had a high fever. When this happened, I first took him to the local health centre, who gave him medications, but his conditions did not improve. I therefore decided to take him to the district hospital. It was from here that they referred Innocent to QECH, and we came by ambulance. At QECH, Innocent was diagnosed with Wilms tumour, which affected his kidneys. At first, I was very disturbed to learn that my grandchild is suffering from cancer. However, when I came here and saw how the doctors help him, I'm feeling better. Unfortunately, Innocent's tumour relapsed, so he is currently receiving treatment for this. Nurse Ellen explains, Innocent was diagnosed with Wilms tumour. He is on chemotherapy, including doxorubicin, and is also receiving radiation therapy. Unfortunately, his cancer came back and his prognosis is not 100% certain at this stage. Linda tells us, the whole process has affected me emotionally because once he gets treatment, it makes him vomit, gives him stomach aches, and has resulted in him losing his hair. Innocent is doing much better now compared to when we came in more recently, as he was having trouble breathing. If it wasn't for the treatment provided on this ward, he may have died. The doctors and the nurses are providing Innocent with really good care. I haven't needed to pay for the cost of any of Innocent's medicines. This has helped me a great deal as I could not afford to buy the medicines on my own. Staying here at the hospital for Innocent's treatment has affected me and my family because my family relies on me to provide for them. When I am here, I cannot work on people's land to earn money to feed my family. I would love for the medicines to be regularly available, even in our nearest hospital, so that we can access treatment closer to home. All I can say is that I'm grateful for the donation of medicines here. They should continue their good work. I hope that Innocent becomes a nurse so that he can help others.
Thanks, Hazel. So as you can see from that story, another one of the issues associated with paediatric cancer care is a chance of relapse. And we heard about relapse in one of the other stories already. So that means Innocent's prognosis is not 100% certain. However, thanks to the support of World Child Cancer and the donated medicines, he can get the care he needs during this relapse.
Yeah, and just to say, there's nothing innocent about this boy. As with the cheeky face, he was causing carnage on the ward and was definitely the winner of the loudest. When we were trying to interview other families, he'd just be going, ah, up and down. Definitely entertained us.
So the final story is with Tim, I think.
Ruth says, my name is Ruth and this is my daughter Eliza. I run a small-scale clothing business that sells wrappers. We live near Lucenza, which is about 4 hours from Blantyre. Eliza is such a sweet child. Before her diagnosis, she was going to school. She was energetic and always playing with her friends. About 6 months ago, Eliza started to become unwell. She wasn't able to walk properly. At first, I thought she had injured herself as she began to limp when she walked. She then started to lose weight and started to experience stomach pains. It was at this point that I took her to the health centre where they determined that she was anemic. They referred her to the district hospital in Licenza for further tests. They found a swelling on her spine, which they initially suspected was tuberculosis. They subsequently started on her treatment. However, her stomach started to swell. They therefore referred her to the QECH in Blantyre. Tests and scans were carried out that determined that Eliza had swellings on her stomach. They told me that the swellings were cancerous. The cancer was already quite advanced, so Eliza had to start treatment straight away. Eliza first received treatment for 3 months and then was discharged. She is now back for another round of treatment. It disturbs me a lot to see her receive treatment as she becomes unwell. It pains me a lot, but I know I need to be strong for my daughter. Nurse Ellen explains, Eliza has Burkitt lymphoma and she is receiving chemotherapy, including doxorubicin and cytarabine. She unfortunately relapsed after her initial treatment and so is back to receive further treatment. At the moment, there is a 50-50 chance that Eliza will make a full recovery. Ruth explains, it would have been a problem if I had to pay for Eliza's cancer treatment. The living costs are high, and even now my family at home is suffering as I have to pay for the transport costs to bring Eliza here for treatment. My family is heavily affected as I have another child of school age that needs his mother, but I have to be here for Eliza. Eliza is doing well now. She is responding to the treatment and is able to play with her brother. She can do almost everything she could do before she got sick. When all of this trauma is over, I want her to go back to school. I want her to grow up to be a doctor so that she can help small children like herself with cancer. It pains me to be here seeing other children suffer with cancer. There is a need for more support here. Children are suffering from cancer and it is hard to see. It would be helpful to have a more sustainable supply of medicines so that children, where possible, can take some of their treatments from home. There are children here whose conditions are getting worse. Please help us receive more cancer medicine for this ward. For companies who have already donated, thank you for providing these medicines. The doctors are providing this treatment to those who need it here.
Thank you so much. This was the sweetest family. It was such a pleasure to meet them and speak to the mother. And when we spoke to Dr. George, I think part of the same day, he was just saying how unwell Eliza was when she first came in and just how much better she is now. And I almost couldn't believe the difference in what he was describing even in that time. So here you probably heard in the story around Eliza was misdiagnosed initially, and that was one of the kind of barriers, I guess, to accessing childhood cancer treatment. There was also a delay in actual diagnosis, which then resulted in that late presentation we were talking about earlier. So that meant that she had to start treatment straight away because it was quite advanced. We've also heard that she unfortunately relapsed, and so the treatment regime that she's on now is a lot more complicated, but they are obviously ramping that up. And also just the fact that it is a bit unknown about how that's going to go, and that's particularly in relation to the relapse, and also the impact on the children, or the children are impacted in this family because the mother has to be here with Eliza.
Okay, so now on to our conclusions. So for the next steps, we'll be finishing writing up our content we collect from this trip and send it over to our partner, World Child Cancer. And we'll also be sharing that content internally. We'll be working with IHP's corporate partnerships team to review the updated needs list that we received from World Child Cancer and review it against the programme portfolios from our corporate partners. That'll help us to see how we might expand support for our child cancer programme with our donors. We're looking to send the next shipment for World Child Cancer imminently, which contains approximately 30,000 treatments and a value of around £74,000. And this was actually collected today, as we mentioned earlier, so it should be arriving in Malawi by the end of this week. So IHP's programmes team, so Hannah and I are in the programmes team, identified NCDs and specifically adult and paediatric oncology as one of the 3 main therapy areas to focus on for this year. We're delighted that thanks to our donor and funder support, we've been able to strengthen this programme with World Child Cancer in Malawi. So we'll be taking learnings from this trip forward into our continued strategic business planning for 2024, where we're looking to expand on the work we do with World Child Cancer beyond Malawi. And we also work in Cameroon with World Child Cancer, and we hope to expand into other destinations. So far, we've had 5 shipments for World Child Cancer in our plan for next year. We hope that so far this presentation has left you with a greater understanding of the impact IHP's work has been doing and the impact of our donor support, which is so great.
Amazing. All right, so you heard that today was a very special day. Some of you already know this. So we're going to hand it over to our Director of Communications and Engagement, Hazel, just to introduce this next part of the presentation. Oh, get both mics. Okay.
Special treatment. So yes, as Adele alluded to earlier, today is Giving Tuesday, which is a day of global giving, encouraging people to give in all of its forms. But we are taking part in the Big Give Christmas Challenge, as many of you will already know. And that means that from now until the 5th of December, every donation made through the Big Give will be matched. And all of the funding raised through this campaign will go towards supporting our partnership with World Child Cancer. So improving access to medicines for all of those patients that we've heard about already. Our kind of total budget for our target for the campaign is £70,000. So half of that we have matched already. So we're hoping to raise £35,000 from individual donations. So what we're going to do next is, we've obviously heard some amazing stories and it's great to hear, but we have a wonderful video where we'll be able to hear from some of the patients and doctors personally. So we can just play that.
Chimwe chimandisangalatsa ndikamakhala ndi makolo yanga amandisamala bwino komanso amandisunga ndi mphamvu. Ine ku nyumba kwathu ndimakonda kupita ku sukulu kuwerenga komanso kuphunzira. Ku nyumba kwathu kuli mavuto osiyanasiyana, ndipo kudwala ndilipa mavuto ambiri. Chifukwa choti ku nyumba kwathu kuli njala yamene ndikudwala muno kumakhala ndi njala, chifukwa choti ku nyumba kwathu konse sikuoneka bwino ndi kumudzi.
Moyo mwanawo unali wabwino zedi nthawi yasanambe kudwala. Yendero kusewera ndanzanga amasewera bwinobwino. Kugwira ntchito pakhomo amagwira ntchito bwinobwino.
Asana ndipeze ndipale ndakhasa sinkadziwa kuti ndi chani.
Chizindikiro chimene ndinazindikira mwana kuti ndikhasi chimene akudwala, nthawi imene amadandaula m'mimba kumapweteka. Anadandaula kwa masiku mwina 3 days. Anadandaula kwa masiku 3 days. La 4 days nimene mazapeza mwana kutani anamba kutupa mbali imodzi kumanzere mu nthiti mwake nimipa anamba kumatupa. Tandiza mankhwala nachipeza nditapita chipata chaching'ono. Tazacho chipata chaching'ono mama nditumiza kuno ku Queens. Ala nditumiza ku Queens anamuona mwana ndimene anditumiza ku ward ya Kasa.
We have 34 beds in the ward. Most of the times the ward is full with patients. On top of that, we run clinics every day. So on average, we see about 10 patients. That's on daily basis.
We have got patients that are come with advanced disease requiring a lot of medicine, but also those patients, the medication that we need for those patients are scarce.
There are a lot of challenges that these families face, including the financial challenges, because they are coming from far to coming here to receive treatment, as well as coming here for the checkups. So it's very challenging for them in terms of financial resources.
Ndingogula mankhwala ndi vuto kwa ine. Chifukwa sindingakwanitse kugula mankhwala kuti ndi mwanayo athandizike. Zikufunika chisamaliro yambiri ngati ndalama kuti ndikapeze mankhwala kuti mwana asamalike, koma sindingatani kuti sindingakwanitse. champipo ndinali ndisanachilandire kwenikweni tamva zoti mwana wangu apezeka ndi khasa ndimakhala okhumudwa kuti zatheka bwanji kuti mwana wanga akagwire ndi nthenda ngati imeneyi koma ntaona zokuti wamba kulandira treatment ndinachilandira kwambiri popeza nthawi imene analipo oyamba ndi pano ndinasiyanitsa ndi pano pa ndinachivomereza kuti mwana wanga anapezeka ndi chani ndi khasa.
IHP is playing the most important role in providing us with the drugs, because the hospital do not most of the times do not stock all the drugs that we need. So with the coming of IHP to provide us with these drugs, it's very, very important, because it means our children are getting the drugs that they need.
Ine umwe wanga nimembekezera zabwino kutsogoloko azakhalenso ndi mphamvu pa nthawi imene ngati imene analili kale komanso kukhala ndi kumagwira ntchito imene amagwirira kale.
Ndikadzakula ndimafuna ndizakhale nesi.
To supporters that are contributing to IHP donations that come to us, I would say, first of all, I would like to say thank you so much for what you are doing. You are investing in the future of this nation, but not only in the future of this nation, but you are also investing in generations to come by giving essential medicine that treat cancer. So please continue to give.
As I said, yeah, any donations made between now and the 5th of December will be doubled and will go towards supporting children with cancer in Malawi and Cameroon. So anything you can give is hugely appreciated. Thank you.
Great.
And I think we're going to do some questions now. So
yeah, so over to you guys. Like, if you have any questions about any of the content you've shared, any specific things that came up that you want to know, over to you. So that's in the room and online. So let us know. Yes. Ghazala's got a question.
Should I just send it?
Yes.
Okay. Well, thank you very much for the great presentation. And just before I jump on my question, I want to post a message from the team in Malawi. It was absolutely incredible to have to benefit from the visit that you paid to our program in Malawi. It was different in nature. We have always had donors visit to the country. This was a partner visit, and it is greatly appreciated. So on my question, I want to know from your experience visiting the program, what was it like that you that made it different, like from your perspective, in the sense that you had no idea about it, but being in the field and seeing the impact of the partnership and the donation, that put it in a different perspective.
Yeah.
I would just be interested to know. Thank you.
Well, why don't you start?
So I think what was really helpful for Johnny and I to see when we were there is we had some idea of what some of those challenges might be, but I don't think I realised to the extent that that impacted families and how many different challenges and barriers there are to accessing child health services in the country. And as we went through, you've heard that in the stories as well. I think in order to, by being there and actually meeting the families, you can really relate to the very specific challenges and impact on them as people. And I think that we really wanted to make sure that we're capturing that in the comms that we were gathering as well. And I think the other thing that really surprised us, but was
I think that medicines is a really key part of this, and how impactful that is through the partnership, and how, you know, basically what we found was that families were almost not unaware that they were free, but like that was just almost something they didn't have to worry about. And I think that is thanks to the partnership that we've created. Like that hasn't been something that they've had to be concerned with. So I think, you know, I was almost glad to hear that they didn't know that it was donated product, but I thought, well, that's a really nice thing that they don't need to worry about that. It's provided, it's there. And particularly just because that's already such a challenging time for families. You know, being able to support them in this way was just, I really saw the impact of that when we were there, very much so.
Yeah, absolutely. And I'd just like to, I totally agree with Hannah in that respect, the extent to which it affects families. And I guess it was surprising, and I had some idea already of the challenges that families were going through, but hearing from patients like the ones we showed in the case studies earlier, it was huge to hear the amount of distance that families were traveling from all the way from the northern tip of Malawi. And this is a city far, far away from their home, wouldn't be able to visit home for such a long time. The challenges that they're getting through to receive cancer treatment are so great. But I guess, on the other hand, the amount of hope, I guess I was expecting with the families affected by cancer, I guess the instinct is that you'd feel a bit hopeless, and the kind of the prognosis and all the difficulties emotionally you're going through. But actually, what we experienced was that lots of the people we spoke to were actually really hopeful, and they were really pleased about the treatment they've been receiving, and they knew that there was treatment and people caring for them at the hospitals in Blantyre, and it was just amazing, the amount of hope.
And I think when we realised how long the children had to be there for lots of different reasons, to receive treatment, but because they live so far away, they had to, you know, we heard stories there about patients and their families being there for 4 months. And that's a huge amount of time. And when you then look at the ward and you think, oh my goodness, that's such a long time to be there. So the work that World Child Cancer is doing to enrich that space, and, you know, IDA's a real integral role in that, of providing some of that enrichment activities and just making it a fun place, was just, I can just see how that elevates the holistic care of those children on that ward, on top of then our partnership. So that was wonderful to see.
Great.
Yeah. Any other questions?
Old.
Oh, right at the back. Okay, we're going to have to pass the mic.
So we saw that there were activities, obviously, in the pictures. Are they on a daily basis throughout the day, and how are they structured so that they accommodate for, let's say, different age groups of these children?
Yeah, good question. So when we were on the wards, there was a dedicated area with the sort of activities for the young children who've been affected by cancer. So there's not only the children who are suffering from cancer, but also some of their siblings as well were on the wards. The activities are run throughout the day. So because we visited on 2 different days to Queen Elizabeth, and the children that, you know, they were running around on bikes. It was structured. They were playing puzzles, they were playing with toys, they were watching films. There was always something for them to do. So that, I guess there was a wide range of enrichment that you could.
So it usually started like a film. We had like a film in the morning. So totally watched a bit of Peter Rabbit, not gonna lie. And then there was a specific Lego session which looked really fun. And what I also loved was that they have tablets, like, you know, like an iPad, that were going around the ward, and I think they've been quite helpful for like different treatments and procedures, but also for maybe children that can't, it's not easy for them to leave their bed because they're either too unwell or they've got mobility issues at the moment. So there was always something, it was like catered to each child, which I thought was really nice. Yeah.
Any other questions in the room? George?
Thanks, Johnny and Hannah, for the great presentation. Not a question as such, but I was just imagining and thinking about how this partnership between IHP and WCC contributes and impacts on the Malawi's progress in achieving universal health coverage by 2030. Yeah, is it something that you discussed or you imagine the kind of impact that this has on that progress. Yeah.
That's a really good one.
You already have.
Oh yeah. Wow, okay. Nearly took two. So we did, I think we did ask this to Richard, and I think one of the quotes that I probably shared with you at the beginning was that because there's not this ability to, because of diagnostic capacity, but also training in clinicians at different levels of the health system, it means that, you know, children are going through primary, secondary, not getting diagnosed properly, and it only seems to be at the tertiary facility at Queen Elizabeth that they are getting the right care. So one of the things that World Child Cancer is doing is trying to educate those clinicians by providing training all the way down the process. So right the way down to the primary healthcare level. And I think that that's trying to then take the burden off the tertiary level, because there are some things that, if it was caught earlier, would have been treated, it would have been easier to treat, and then the prognosis would have been better. So it also would then eliminate the fact that, you know, families need to then move into a hospital far away from their family, and that's impacting their livelihoods and other children at home as well. So I think that kind of work, you can definitely see how that is impacting this universal health coverage, because it's taking the burden off the tertiary level by trying to catch this sooner in the health system, if that makes sense.
That's great.
Awesome. Any other questions online? Yes. Do you want to read them out?
Yeah, a few questions online, actually. So let me start with... So Charlotte asks, you mentioned new opportunities working to help support children with cancer in other countries. Could you tell us more about your plans with this?
For sure, yes. So we work in our paediatric oncology program. That's primarily with World Child Cancer, and the other countries that we're exploring. So we already work in Malawi and Cameroon, and we've shipped a few shipments to Malawi and a couple as well to Cameroon, especially recently. We've been shipping to Cameroon. We're also exploring a few new countries. So the two ones that we're looking into, so nothing confirmed at this stage, but we're hoping to expand our portfolio with World Child Cancer to Ghana and Myanmar. So hopefully in the future, we're able to share some of these chemotherapy products, such as the ones that we've been shipping to Malawi, but also some of the ancillary care products that cancer wards need as well, to those new destinations. And we have a couple of corporate donors who are on board as well with that future destination. So yeah, we're really hopeful for expanding that program in 2024 and then beyond, with hopefully further countries to that as well.
Question 2. Yeah. This is from Helen. Oh, sorry, no, it's from Laura first. Thank you for the amazing presentation today. Are there any long-term predictions on medicine affordability in Malawi, considering Malawi's reliance on agriculture and its susceptibility to climate change?
That's a good one, Laura. Thank you. I think from what we understand, the way that Johnny was explaining how the health system works in Malawi is that the government try to fund as many of those medicines as possible. So one of the main barriers at the moment is that you heard particularly around oncology, they're only able to cover 10%. So I think that's because they have a limited pot within the Ministry of Health budget. And so that would need to change for them to be able to take a higher proportion. So with other oncology programs that we have, that is a similar situation. And what would need to happen is that is funded at the government level more and more, so that it's taking that pressure off donors. But it sounds to me that the strategy in Malawi would not be to let patients cover it. And we didn't really hear any cases where that was the case. But obviously it could be. But I think it's mainly government supported. So it would be about looking forward, how can that economy build so that there is sufficient budget within the Ministry of Health to be able to afford a higher proportion, if not all, of the oncology drugs required for the country.
Yeah, absolutely. And I think in the long term, ideally countries such as Malawi would be able to support themselves and not rely on donor relief work. So in partnership with World Child Cancer, we're helping the country to support its own healthcare system, and hopefully in the future they will be able to support more percentage of the drugs that are needed in country. It is a country which has many different issues, and of those, health is only one proportion. So it's difficult for that government, especially, to spread around the resources that they have to the healthcare in country. But yeah, hopefully one day they'll be able to tackle that more effectively.
Great, thanks. I think that actually covers Helen's question as well. She asked, I'm curious to know the extent of which the donations are sufficient. Is there any sign that the government may be able to fund more meds in the future? Yeah. Lots of encouragement also on the chat about the presentation and the stories we've heard. So great, thanks, Gail.
Great. So hopefully everyone can follow on social media some of the other stories being shared this week as part of the Big Give. And I think for those online, unless there's other questions on the floor, we'll probably leave it there. But thank you so much to everyone joining online. So I can, if that's all right with you, Rich, I can come off that now. Lovely.